Thank you very much. Today I will discuss the repeat class of macular infection, related BCG and associated some complications. I already discussed a different pattern of BCG in myocardial infection as well as myocardial ischemia. Today I will discuss different type of BCG as well as to show you a different type of complications and different pattern of presentation of myocardial infection. So first of all, how to recognize anterior myocardial infection? ST elevator, TMI. You know this 12 bleed disease. Those patients having chest lead changes of ECG as well as lateral lead changes of ECG. That means ST segment elevation with QOF formation in the precordial leads, usually B1 to B6, and high lateral leads 1 and AVL. And sometimes there is presence of reciprocal changes. Those patients having anterior myocardial infection, he or she will develop reciprocal changes of the opposite lead. Usually, in case of anterior myocardial infection, patient develop reciprocal ST depression in the inferior leads. That is mainly 3 and AVF. So, the magnitude of reciprocal changes in the inferior leads is determined by magnitude of ST elevation point 1 and AVL, as hence may be minimal or absent in anterior MI. Pattern of anterior myocardial infarction. Pattern. What is the pattern of anterior myocardial infarction? Anterior. Anterior infarction can be confusing with multiple different terms used to various infection pattern. So the different pattern, septal, anterior, lateral, these are the different pattern. But you know, septal V1, V2, sometimes anterior septal V1, 2, 3, 4, and lateral 5, 6. And extensive when patient having V1 to V6 as well as 1 and AVL, this indicate extensive anterior myocardial infection. So for your kind information for undergraduate student, you must know the anterior as well as extensive anterior myocardial infection, which lead with SARS. And there is a different pattern of ECG, sometimes indicate complicated or left coronary artery or other coronary artery myocardial infarction. So this is not for you, but this is important. Anterior inferior infection due to rapid LED simultaneous ST elevation in the precordial and inferior leads due to occlusion of a variant type 3 LED that wraps around the cardiac apex to supply both anterior as well as inferior ventricle. This is the one of the important ECG for you. You always try to localize your findings. Okay, you try to look at your findings. This is the ECG. This is anterior lead and AVL 1, AVL, and this B1, B2, B3 as well as B6. So this patient having ST elevation V1 to V4. This is ST elevation. When you will call ST elevation, when you will draw a line, isoelectric line, that is mean PT inter PT. Beginning of the P and ending of the T. This is called isoelectric line. When patient having elevation of the line, elevation of the ST segment above the line, usually in precordial least 1 millimeter or more is significant, and chest lead 2 millimeter or more is significant. That is called ST elevation. And when ST segment is depression, that is below the line, isoelectric line is ST segment is depressed to the isoelectric line, that is called ST segment depression for that region. this patient having ST segment elevation usually more significant in V1 to V4. That is 1, 2, 3, 4. So this patient having ST elevation in the maximal anteroceptal as well as QF. This is called pathological QF, usually present V1 as well as V2. So what is pathological QF? Pathological QF means deep and wide of the QF on the corresponding RF in relation to corresponding RF. When patient having deep more than 1/4 of the corresponding RF, this RF deep more than 1/4 and wide more than 1 small square. This is pathological QF, and pathological QF always indicate myocardial necrosis. Myocardial necrosis. So this is a ST segment elevated myocardial infarction. What are the positive findings present in this ECG? ST elevation in the maximum V1 to V4, QA V1 to, and some subtle ST 1 AVL 5 with respect to some ST elevation 1, 2, as well as 5 with reciprocal depression in the 3. Reciprocal depression 3, and there is a hyperacute peak TRV in V1. This is hyperacute because this TRV is more than 10 small square, 5, 10, more than 10, more than 10. Usually in TF, in chest split up to maximum 10 millimole, and in chest split 10 millimole. That means 2, 1, 2 square. When more than 2 square, 2 large square is hyperacute. Tall peak and in limblets or augmented is up to 1 large square. So these features indicate hyperacute anteroceptal limb-wide or anteroceptal because this patient having V1, V2. Another ECG hyperacute. Not discuss. This is important. This is same ECG, same patient. So this is typical ECG presentation. Okay. ST elevation 1 AVL as well as V1 to V5, and there is GST pathological PA also present, and there is ST depression is here. Okay. So this is ST segment elevated myocardial infarction. This is another ECG. Anterolateral, sometimes anterior, sometimes some authors said extensive anterior, some others said anterolateral because this patient having 1 AVL. Look carefully, 1 V1 AVL, okay, and V1 to V6. All are the leads, and as well as reciprocal changes of the 2, 3 and AVL because this patient having ST depression. হ্যালো শোনা যায় কথা
জি স্যার
শোনা যায়
ST depression, this patient having extensive myocardial infarction, so involving 1 AVL as well as all of these chest leads, and this patient having also reciprocal changes in the opposite leads, usually 2, 3 AVL. So this is the typical ST depression. This is more predominant in V3 and ST depression. This is ST depression. This is ST depression. And we will draw isolated line, PT line. There is ST depression. ST depression. And this patient is ST elevation 1 AVL and V1 to V6. So first of all, as well as pathological proof, you always try to know the ECG. What is the diagnosis? Okay, then we will give subsequent answers. This is another ECG, extensive anterior ECG. Okay, so one AVL, but this patient having more involvement chest bleed, next segment elevation, pathological POA. Okay, and this patient having one extrasystole, premature ventricular contraction, and as well as this patient having history depression in the opposite legs. So ST elevation, we want to be 6, but more as well as 1 AVL, more marked mentioned before minimal residual checks, as well as QA presence in the 1 to reduce RF 3 4. This is another examples of ST elevated myocardial infection. This patient having Anteroseptal lateral, anteroseptal more involvement we want to before, because this patient having we want to before resolve findings pathological PA, ST, this is pathological PA, pathological PA, pathological PA. This is ST elevation, biphasic TA, and as well as 1 ABL and 5 CCs, ischemic changes. Other ischemic changes, ST depression, T inversion. Okay. This is another presentation of extensive. This is called thumb stoning pattern, extensive anterior myocardial infection, hyperactive distal, ST elevation, sinus tachycardia, prominent stress changes on the ST segment. This is another anterior inferior. This patient having anterior inferior. This is anterior, this is inferior, inferior to 3 ST elevation. This is not for you. This is coronary artery. This is not. This is another example of ST elevated MI with RBP. This is in one. This is another example. This is not for. This is the pattern of TF pattern abnormality in the different type of ischemic as well as myocardial infection. This is another. This is not for you. This is ischemic changes. This is ischemic. Sometimes you will face this type of myocardial ischemia, symmetrical TF inversion. So all of the precordial leads as well as 1 APL and extensive anterior myocardial ischemia. This is another term is Olen syndrome, because the scientist who was invented this type of ECG and he diagnosed this type of ECG for that region. It's extensive anterior and lateral myocardial ischemia. This is another STA depression, ischemia. Basically, this is myocardial ischemia, not infection, ischemia. ECG diagnosis myocardial ischemia, but ECG not always indicate myocardial necrosis, but when patient showed positive cardiac biomarker, labeled as myocardial infarction, ST elevated or non-ST elevated. This is ST segment elevated myocardial infarction. Okay, so a lot of ECG, not for you. This is also, this is so it's important. This is another ECG, myocardial ischemia, myocardial ischemia. So we will observe carefully. This is myocardial ischemia. So typical ST segment depression, T inversion, sinus deviation. Wave inversion recorded leads no mark one two three four. So this is the hyperacute wave. Inflammable infection. Last few slides shows anterior and now some importance talks regarding inferior myopia infection. You know, inferior wall of the ventricle, usually left ventricle is more marked, or sometimes right ventricle. When patient having coronary, right coronary artery, and sometimes left circumflex distal portion will involved of that region. This patient develop inferior wall myocardial infection. Usually 40 to 50% of the all myocardial infection patients are inferior, so more or less 50-50. And generally more favorable prognosis because this patient usually develop less complication, less more round complication, that is ventricular tachycardia, fibrillation, or pulsar spondylitis. And 40% patient with inferior MI component right ventricular infection sometimes. And this patient also develops severe hypertension. In response to nitrate and general have those prognosis. And 20% patient inferior MI develop significant bradycardia secondary or third degree heart block. For that reason, this patient have an increased hospital mortality rate is more than 20%. Sometimes inferior infection has to be posterior infection. So three things you always remember in case of inferior myocardial infection, patient having solely inferior MI, solely inferior MI with RV right ventricular infection, or inferior MI with posterior extension, posterior MI. So this is important for inferior myocardial infection. So how to recognize ST elevation and leads to 3AV. ST elevation leads to 3AV. Progressive development of the cure into 3AV. Progressive development of cure into 3AV. And sometimes reciprocal change, ST depression, AVL as well as 1. So 3 diagnostic point for inferior myocardial infection, inferior ST elevated MI. Three things, always write these three findings as well as patient is heart rate and rhythm. Is there any bradycardia? Is there any evidence of heart block? So ST elevation in list 3 AVF and progressive development of the same leads ST depression and respiratory changes. Artery already mentions inferior MI RCL says already, so this is not for you. This is the inferior myocardial early phase. Early phase. This is image of the features and ST segment elevation. This patient having true NAVG, NAVL, and also pathological QF. Hyperacutic QF into 3 AVF, AVF with loss of R height, and earliest elevation and QF formation in 3, and reciprocal ST depression and TAV inversion AVF. So, hyperacute, 8 tier, big tier, 2, 3, 2, 3, and AVF. And relative loss of R finance, this is loss. This is loss of having pathological care and early ST division and care information. This is ST division and pathological, and this is reciprocal change. Sometimes one, maybe this more than one, and stimulation 3 is more than 2. This suggests RCA function. And okay, so this is not for you, but one more 3 is more than 2 in those favor of RCA function, and 2 goes higher than, say, goes in favor of L6 abortion. So this is inferior macula infection. So mind it, this is the all findings are present in this disease. This is another example of ST's inferior macula infection. This is another example. 2-3 ABF, and you will search these 4 leads to 3 ABF and ABF. There is changes, residual changes, and there is ST segment elevation, pathological care, height of REF. So all are present. All are present within these 4 leads. Within these 4 leads, all are present within these 4 leads. Another disease here. Tachycardia, patient having sinus tachycardia, ST segment elevation, pathological fear, as well as ST depression, 1 ABL. So all are things within limits. All are things within limits. In inferior MI, always starts within limb and augmented lips. So mark ST elevation to 3 ABF with early care, visually 3 and ABF reciprocal changes. Okay, and ST elevation 3 is more than 2 goes in favor of RCA operation. And 1 ABF ST 1, yeah, reciprocal changes 1 and ST elevation we want to. So let's start operation as RBA infection. Okay, RBA is not important for you. You mentioned inferior macula infection. This is another. This is for myocardial infection inferior. This is all features are present. All features are present. This is reciprocal changes 1 and as well as 1. This is another ST segment elevation infection. Sometimes this is confused with acute pericarditis, but some points are present that against acute pericarditis, because in acute pericarditis all of the leads usually shows ST segment elevation with concavity upwards, but and in acute pericarditis ECG shows global changes, not prediction to any particular pattern. In acute pericarditis, global ST segment elevation and AVR ST depression. But in my ECG, shows ST segment elevation in the inferior territory as well as reciprocal changes of the anterior territory. For that reason, this is not acute pericarditis. This is goes in favor of ischemic changes. That is ST segment elevated MI as well as reciprocal changes of the anterior leads sometimes may be present. So this is goes in favor of ST segment elevated myocardial infection. This is another hyperactive ST segment elevation, massive ST segment elevation. Massive 2-3 ABF and also depression. So today I will discuss all myocardial infarction related diseases. So you people try to remember, you people try to memorize, you people try to understand how to diagnose and how to interpret and how to give answer during examination in related to myocardial ischemia and myocardial infarction. First of all, when you will see the ECG, first of all, you always try to diagnose. So, what is this? This is myocardial infarction, this is myocardial ischemia. And then, which territory involvement, anterior or inferior? Okay. So, thank you very much. Any question?